Welcome to the Bronchiectasis and NTM Association podcast, where we're here to share valuable insight from leading health experts, heartwarming stories from people living with bronchiectasis and NTM lung disease, and the latest in health research and treatment. Please subscribe, follow us on social media, and visit bronchandntm.org to learn more. Just a quick note before we get started. This podcast series is intended for educational purposes only and is not suitable for medical advice. Please consult your medical provider if you have any questions. Welcome back to today's episode for the Bronchiectasis and NTM Association podcast. We are here with Dr. Ahmed Hamdi. Dr. Hamdi is an assistant professor of medicine at Baylor College of Medicine in Houston. He serves as a co-director of the Multidisciplinary NTM Clinic and the Outpatient Infusion Center. His clinical and academic interests include complex infectious diseases with a particular focus on NTM infections and HIV care. Today, he will provide an overview of medications prescribed for NTM lung disease, including some of their benefits, risks, precautions, and then practical tips on how to take them. This episode has been adapted from the Bronchiectasis and NTM Association's monthly coffee break series. So if you would like more information on a variety of topics, please join us for the coffee break sessions, which are held on the second Wednesday of every month at 2:30 p.m. Eastern. The link will be in the show notes. So Dr. Hamdi, thank you so much for joining us today. To start, could you share what drew you to the field of bronchiectasis and NTM lung disease? And then also we can just dive right into medications.
Good afternoon, everybody. It's my pleasure. I'm really glad we're here so we can talk and chat about all of this. It's a good question. What drew my attention to this? I think when I first came down to Houston and Texas, I noticed how much the volume of this disease has been kind of really more than it used to be. And I did a lot of my training up in the Midwest. We didn't used to see such amount of patients, and I'll touch base on that during the brief presentation that I have. But I saw that there is a high need for multidisciplinary approach. I saw a lot of patients lost in between the different subspecialties and a lot of the community physicians. And that's why I really thought that we need to do something about it. And that's when we created our clinic, I think three and a half years ago now, down at Baylor. What I'm hoping to do is really just give you some brief introduction about some of what these mycobacteria are and talk about the antibiotics. I know a lot of you on the call are really experts and have been dealing with this for a very long time. But maybe some are not and some are new and they're just like curious to understand more about it. And I try to keep it as informative as possible, but also, keeping it not to, a level that's too complex and a lot of kind of medical language in it. So I hope you guys gonna be able to get some benefit out of it. So we're talking about NTMs, which is nontuberculous mycobacteria. From the name, this is mycobacteria, that's not TB. A lot of times you'll see some physicians get confused, or sometimes it's in your chart somewhere, and then you'll get these panicking messages that you have tuberculosis or you have TB. This is not TB. This is everything that is not TB. That's what the name means, non-tuberculous mycobacteria. So it's kind of a related, but not really TB. So we're going to be talking about those today. I don't have any related disclosures. I give educational material and podcasts to patients as well. So we're going to do a little bit of introduction. I didn't want to dive into the treatment without, at least at the beginning, tell you a little bit of what I feel is important information about what are these pathogens that we're talking about. And then we'll talk about the treatment decision and the common antibiotics and some of the key factors or side effects that you will hear about. So these NTMs, these non-tuberculous mycobacteria, these are everywhere around us. And that's what makes them kind of challenging because it's impossible for you to completely isolate away from those. So these are environmental, means they are in the soil, they are in the water, they are in the shower head, they are really around us all everywhere. So it's impossible, again, to be like completely in a bubble away from those. Now, it's worldwide problem. This is not something that's only in Texas or only in the United States. This is something that is everywhere. Now, sometimes you'll see certain areas have more NTMs reported than others, and we think might be related to humidity and how much out of that pathogen is able to be available for the patients to inhale in and out. Plus, the species could be different. Like, what we see in the United States as number one might not be the case in Europe or might not be the case in Asia. So the NTM species can be different depending on where you are. But again, this is a worldwide disease, something that, everybody is trying to deal with. Now, it's not a reported disease. What I mean by that is there are certain infections or bacteria that the lab, according to law to the United States, has to report when it grows. So we have very accurate data about that. TB is one of them. Again, the scary cousin of what we're talking about today. Once it grows on somebody, the lab has to report it to the state. So we have very accurate data about how much, we have of this every year. That's not the case with NTMs. NTMs are not reportable except in few states, I think 5 states in the country. So we don't have very accurate data. If you ask me how many patients every year are being diagnosed with NTM, we don't really know. But I shared this picture of one of the data that we have now old from 2010, just to show you that the cases per 100,000 right here to the right, it's different between the different states. And we see some states, including where I am in Texas, for example, have more compared to others. The highest number you'll see out of here is actually Hawaii. So, we think there is some correlation when you're living close to the coast and close to water. There is probably higher risk and higher exposure to it. So even though these are not really very accurate incidence numbers, I think it just tells us that it's not all the same everywhere. But again, there are some areas, there are some states that do face higher numbers of these NTMs. Now, again, we don't have incidence. So incidence means how many new cases are identified. And we don't have very good, very accurate data. But what we all know and believe in is that the incidence is rising. The number of cases that we see now is higher than 10 years ago, higher than 20 years ago. And this is just a map that, again, shows that the certain areas and certain states have higher incidence of NTMs. Now, why is that the case? And we believe there's a few different factors. One of them is that we're now detecting those. We're thinking about them. 20 years ago, the labs didn't know much about this. We didn't do a lot of these special mycobacterial cultures. Plus, we have better medicine now than 20 years ago. So people are living longer. They're going through a lot of medical issues and they're overcoming those. There is a lot of immunity issues, cancer issues that people are surviving and getting treated for that. And it might leave them with a weaker immune system or a weaker body. So we think all of these factors are leading to us detecting more of this and knowing more about it. But we don't really know if it's just like there is more of it now than 10 years ago, or we're just having, better labs, better physicians, and more patients. Now, again, I didn't want to bore you with the details, but I wanted you just to know about some of these. Again, there's more than 200 of these NTMs, but there is usually a handful of these that we deal with more frequently, like maybe 5 to 10 of these different NTMs. So how we classify them, how your doctor is going to look at this, most probably this is the most common way: rapidly growing or slowly growing. Rapidly growing means some mycobacteria grow within a week. And this is, in the world of mycobacteria, considered rapid. So when you give the sample, within a week, I will know that this is growing. And there are different of these mycobacteria. You hear about abscesses, which is a challenging one, Chelonia, Fortuitum, among others. Or there are the slow growing that take more than a week. Some of them will take weeks and weeks to grow. And that's why you will see a lot of times your doctor will wait 6 weeks before they can actually pick up the phone and tell you your culture is negative. Because again, these mycobacteria, these AFB cultures, takes time to grow. This includes the MAC, which is kind of the most common and the most common species we deal with in the country, Mycobacterium kansasii. These are all slow growers. And that's why they need special lab. They need special order. If you just give, in an urgent care, a regular sputum culture when you go, they usually don't send those. They do send special, just normal sputum cultures that looks for bacteria. But mycobacteria need a specific kind of culture. Not all labs deal with it. And again, a lot of times you'll need weeks for them to finalize. One of the confusions some patients tell me is like, why is my doctor deciding not to treat this? Like, what are the factors that you look at? This is one of these factors. So if I'm seeing you today in the clinic and you gave a mycobacterium culture and that AFB grew, if it's growing something like Mycobacterium mucogenicum or Mycobacterium gordoniae, I will be much less worried. And I will probably tell you, of course, among other factors, I don't think this is something we need to treat or jump on antibiotics right away. Well, you look to the opposite side to the right, Mycobacterium intracellulare, part of the MAC, Mycobacterium kansasii, Mycobacterium avium, abscesses, these do have higher risk. They have more virulent factors to cause disease and infection. And that's why, again, that what is the bug, what is the mycobacteria itself is one of these important factors. So they're not all treated equal. And again, this is just a handful of those. There are more than 200 of these. So that's why it needs a lot of expertise as your physician analyzing that data. And then the other question is, why me? And we don't know 100% why certain patients get the disease, but this is the theory that we know. There are these, rings of risk factors. One is the host. So we're all living in the same city. Why some of us gets it, why not? There's probably some risks that the patient carries. A lot of them are the anatomy of the lung. So you have bronchiectasis, you have cystic fibrosis, you have something that made your lung at higher risk of acquiring this. And there is a lot of other things that affects your immune system, whether it's a certain agent you take, certain chemotherapy, things that will make you, again, more susceptible at higher risk. The other ring you see here is the environment. As we said, there are certain areas, certain states that do have higher exposure to these kind of mycobacteria. So that will put you at a higher risk. Plus certain activities, somebody who is around the soil a lot, who works in their backyard, certain risk factors will put you at higher risk of getting that infection as well. And then there is some host susceptible phenotype. We don't exactly understand why, but the majority of people who get these kind of infections show a certain similarity. So usually thin, postmenopausal, older females, they have higher risk to acquire this kind of infection, never smoked in their lives. So there's a lot of work in the background on the genes of why this is happening. So this is what I was talking about. How does your doctor decide what the guidelines that the physicians read to decide that for Mrs. X today, I will start treatment? I always tell the patients, I look at this triangle of three things: your clinical symptoms, the imaging and the x-rays, and then the microbiology, meaning what is the mycobacteria. So if you have symptoms, what are the symptoms, how risky they are? There are some red flags for us. You'll see the doctors asking a lot about your appetite and weight and fevers and night sweats, all of these different things. The imaging is the other corner of that triangle. I want to see how your CT scan looks like, what kind of disease we're dealing with. Some are riskier than others. And then the third corner is the microbiology. As we talked, what is the exact mycobacteria, how much of it is growing, and all of these different factors. And then the final thing before we dive into the actual treatment is airway clearance. It's such an important fact. And honestly, it's missed a lot, especially if you are going in let's say a community clinic, and it's not like a big center where they have all these resources. They might not, bring your attention to this, but airway clearance is such an important thing. What does that mean? What is airway clearance? A lot of times, big part of the problem is the secretions. The lung is not able to bring up and clear the secretions because of one reason or the other, all these risk factors that we talked about. So as these secretions plug in your lungs, they cause this circle of inflammation, bacteria piling up, causing infection, and all of that. And airway clearance tries to break that circle. And that's why your infection doctor will work with your lung doctor. They might get you to a respiratory therapist to try to teach you the best way and the interventions we can do, because this is a very, very important part of the treatment for all these NTMs. Okay, now the main topic for today is the antibiotics, and again, I'm going to try and make it as concise as possible. But what I really wanted to do is tell you the names, the frequent names of antibiotics you will hear, and what are the common issues you can expect or the side effects we look at, just to make you again understand what your doctor is looking into. So for these NTM infections, we always treat with a regimen. We never give you one antibiotic because the risk of resistance, meaning the agent I'm giving you today stops working is much higher if it's one antibiotic. So I would always treat you with at least three. Sometimes, depending on the severity of the disease, could be four antibiotics or five antibiotics. So that's why, it needs, a teamwork with this. And the agents could be orals, could be IV, could be inhaled, and could be a combination of all of this. These are the common groups of antibiotics. And, again, I'm just mentioning those so that, what some agents and what some names will be brought up when you're talking to your doctor. So you'll hear a lot about rifampin or rifabutin. We call them rifamycins, macrolides like azithromycin or clarithromycin, ethambutol, aminoglycosides like amikacin. There is a lot of what we call beta-lactams, which are like relatives of penicillin, like imipenem, cefoxitin, clofazimine is another agent, linezolid, and then something like tigecycline or omadacycline. Now, they're not all used in all NTMs, depending on what are you dealing with, what kind of NTM it is. Your doctor might be reaching out to, a few of these to design the regimen that they're going to be treating you with. So let me start with macrolides. Macrolides are the most important agent ever. So in your entire regimen that we're using to treat you, macrolides, which is azithromycin or clarithromycin, are the most important agents. These are oral pills. And, we're going to be monitoring you for a few things when you're taking azithromycin or clarithromycin. We watch you for, stomach upset, abdominal pain, diarrhea. QTC prolongation is just a part of an EKG. When you get an EKG to monitor the electricity of your heart, there are certain agents, and macrolides, one of them, can affect the electricity of your heart. So your doctor will probably ask for an EKG when they're starting treatment. And a lot of time, depending on your risk, then we might repeat those every few months or so. There is also risk of tinnitus or hearing issues. So again, we need to monitor all of these things when you're on treatment. We prefer generally azithromycin over clarithromycin. It's once daily instead of twice daily, a little bit less side effects and drug interaction compared to clarithromycin. And it's an agent that can be taken with or without food. Now, the second one I'm talking about is ethambutol. Ethambutol is kind of the guardian for macrolides. So I said azithromycin being the most important agent that you're getting treated with. Ethambutol, there is a lot of data that when you use it with the azithromycin, it protects it so it doesn't become resistant with time. That's why you'll see that, we add the ethambutol as our second agent to the macrolide. And again, I'm talking generally, depends on what is your infection, what is your NTM, you could be on different agents or different regimens. It's also an oral pill, and it's used in different kinds of different NTMs. I'm mentioning here the common ones, MAC, Mycobacterium avium complex, or Mycobacterium kansasii. The most common thing you'll see your doctor worry about with ethambutol is vision. Now, these are very rare side effects, but again, we always think about the worst and make sure that we're looking for it. So having neuritis, like issues with your vision, color vision specifically, is something that can happen. So you'll see your doctor asking for your eye getting checked. I personally, in the clinic, do a quick, what we call Ishihara color test. If you guys remember this kind of colored numbers inside, and I ask you to tell me if you can see what the number is, just kind of an early detection to make sure you're not having any issues. So, things that we monitor, and it's a pill, so that's an advantage, and it can be used with or without food. Rifamycins, that's the name of the group. This could be rifampin or rifabutin. This is another oral agent that we use in combination with usually azithromycin and ethambutol, specifically in infections like MAC or kansasii. There are certain challenges with rifampins, and your doctor will be checking on your other drugs to make sure there is no drug interaction. And I wanted to make sure I mention here, a lot of you will see multiple different doctors. You have your primary doctor, your heart doctor, make sure that if you are having changes in your medications, you let your doctor who's managing your NTM know, because I don't want you to be getting something that's having any bad interaction. There are some agents, blood thinners, there's some of these medications that can have bad interactions with certain antibiotics. This is one of them, rifampin. So make sure that your doctors know and up to date to any changes happening in your medications. Now, what possible side effects can happen with rifampin? Again, it can have GI side effects. It can affect your liver in a negative way. And again, that's why we usually have routine labs to monitor you when you're on all these different agents, because even though the risk is low, we want to make sure we're doing no harm. One famous side effect of the rifampin is this orangey discoloration of the body secretions. And if your doctor doesn't tell you about it, you can freak out about this, understandably. You notice your urine is orange, your tears are orange, but this is just the chemicals of the medication. It's not really causing any damage. This specific medicine is recommended to be on empty stomach. You can mix it with, some applesauce or pudding or something like that. Aminoglycosides. This is the big monster of NTMs because amikacin is an agent that is very, very strong and very effective against a lot of NTMs. It can be used IV or it can be used inhaled. But the problem with aminoglycosides or amikacin is that these are tough agents and they have a lot of risk profile. So again, one of these medications that your doctor will keep a very close eye on you if they decide to start you on. The most important two issues with amikacin are kidney issues and hearing issues. So if I'm going to start you on a combination of drug that needs amikacin today, I will ask you to have definitely labs to check on your kidneys, and I will ask you to get an official hearing test. And then depending on how you do over the next few weeks or months, sometimes we'll have to repeat the hearing test. So again, just kind of keeping a close eye on you. The inhaled type of the amikacin has generally less toxicity considered compared to the IV. Clofazimine. This is a medicine that you actually don't hear about anywhere else but in the NTM world. It's an antibiotic that we use in combination with the others for different kinds of NTMs. It's a pill, can be given with food. The challenge is it's not commercially available. It's not FDA approved in the United States. It's approved everywhere else in the world for NTM treatment. So that's why you'll see if this is ever brought up by your physician, that it's not easy for them to acquire it. They'll have to go through a certain system unless they are a center and they have that access to the medication and they have that portal available, then they can use it. But this is a medicine that they can't send you a pharmacy. It usually needs to have a consent form from you to sign first, and then it gets shipped to your doctor and he will hand it to you. So it's a little bit of a hassle, but it's a very good drug. And again, it's used on different kind of these NTMs in the treatment. The side effects of it is generally minimum. I mean, it's usually a benign drug, but one common thing is kind of darkening or discoloration of your skin. It's very different from patient to patient. Some will have no issues at all. Some will have like tanning effect, just like feeling that they've been in the sun a lot. And some, they might actually have more darkening to the degree that it's annoying them and they don't want to continue anymore. The good thing is that once you stop it, everything goes back to normal, although it might take some time because, the skin and the pigment washing off you. But other than that, it's usually a benign drug. Of course, again, just like all of the other agents you're on, we will have to monitor you, get blood works, get EKGs, monitor you while you're all of these antibiotics. Linezolid, this is a medicine that's actually not only used for NTM. This antibiotic is used for a lot of other infections, just to name one, MRSA, that you might have heard about. So linezolid is a strong antibiotic, and it has a lot of role in different NTMs. The challenge is using it long-term is a little bit risky, meaning, it can cause issues with your blood counts. It can cause nerve pain. So when you're on it, your doctor will be very careful. Usually we use lower dose than the regular dose for other infections. We use like one pill once a day instead of the twice a day, which is the usual dosing. And again, monitoring with labs, monitoring you for any symptoms. And then finally, there is something called omadacycline. It's, again, part of this big group, the cyclins group. The advantage that it is an oral pill, can be used for different kind of NTMs. But at the same time, obviously, again, just like everything else, we need to make sure you're tolerating it. It's fasting. So this is a medicine just like rifampin that you should take on an empty stomach rather than most of the others that can be taken with pills. It needs to be careful with stomach side effects. It can cause more than others, abdominal pain or nausea. So definitely letting your doctor know so that we can figure it out and change the timing of it and make sure you can take it okay. And it needs to be also separated from antacids and like milk products as well. Before I close up, I just wanted to kind of mention this up that these are a lot of medications. And this is really a partnership. What I tell the patients in the NTM clinic is that, this is something that we have to work together as a team, me and you, because these are a lot of medications. This is a daily commitment, and this is for a long duration of many, many months. So, I sometimes print things like that for them, which has like the pictures of the tablets, or however I can make it easier for you to understand, to take it on time, to make sure you're not confused when you're going home about what is the treatment or what therapy you need to take. And this is not to scare you, it is just to show you how much monitoring your doctor needs to do. And again, just to bring up that this is a partnership. All of these medications, I need to monitor a lot of things while you're taking them, whether it's blood work, it's EKG, it's vision checks and eye checks, it's hearing checks. So again, I know this can be very troubling, it can be expensive, this can be frustrating, but I want you to understand that your doctor is doing this because they want to be safe. The last thing I want to do is harming you with one of these antibiotics and you get into a new problem or a new issue. So trying to keep up with all of this, it's very, very helpful. Again, when you're having a hiccup with an agent, I want to say don't quit. Talk to your doctor. Hey, I'm not able to take this antibiotic, or this is bothering me, or like what strategies can we do with this? Or these monitoring labs, I'm not able to doing them. What kind of monitoring interval can we do? So again, work with this hand in hand with your doctor so we can get you through this journey and hopefully get that infection out of your system. It's kind of summarizing these concepts. These are, and a lot of times, very slow to grow infections. And it's a good thing because there is a lot of them that never progresses. And that's why, you hear the concept of, we call watchful waiting. Well, which means is some patients have some of these growing up in their sputum every now and then, but they have minimum to no symptoms. They have really minimum to no changes in the scans. So we just keep an eye on them, make sure we clear their secretions and closely monitoring them. And that can be enough to clear the infection out. If we decide that we're going to need antibiotics, again, this is a partnership. It's going to take multiple agents for a long duration of time. And I'm putting here the 12 months because that's kind of the general rule of therapy for multiple NTMs that are affecting the lungs. So it is a long duration. But again, working together, we can make it happen. And then finally, again, mentioning the pulmonary hygiene, it's very, very important using these nebulization methods to try to clear your secretions, cough up, and that will just keep your lungs in a better shape. Helping the antibiotics if you're on them, and if not, alone, it can actually be very successful.
Thank you for tuning in to the Bronchiectasis and NTM Association podcast. We hope that you found today's episode helpful and inspiring. You can stay connected by joining our online community, following our social media, and visiting our website for more resources. And of course, subscribe to this podcast and join us next time for more insights, stories, and tips to help you live well with bronchiectasis and NTM lung disease. Until then, thanks for listening and be well.